So now it's all about immunotherapy. The moment we say lung cancer, there is nothing beyond immunotherapy. So even in the era of immunotherapy, where it has significantly improved overall survival, both in first line and subsequent line therapies, not all patients with advanced lung cancers benefit from immunotherapy. So the approximate proportion who benefit are roughly around 30%. Still, 70% of them with advanced lung cancer, especially squamous cell carcinomas, don't have effective therapies. We have few chemotherapies, platinum, gemcitabine, taxanes, and vinorelbine. Other than that, there is no active therapy other than chemo immunotherapy and some VEGFR inhibitors like ramucirumab. So there is no solid survival data for other therapies, and it's quite often we come across patients with squamous cell carcinomas who have progressed post platinum therapy or who are not responding to immune checkpoint inhibitors, who are having a poor GC, and they will become eligible or they will be willing only for oral therapies. So it is very important to address this whole chunk of population who are otherwise unfit or who are otherwise candidates only for oral therapy. So in this particular situation, instead of giving chemotherapy where it may add to toxicity and may not benefit the patient, it is extremely prudent to put them on drugs which are targetable, which are well tolerant, and which also adds life to the patient. So among that, afatinib is one of a molecule which is an extremely potent EGFR inhibitor. It's an irreversible EGFR inhibitor, and its spectrum of EGFR inhibition is wide. Also, it has some wild type EGFR inhibition too. That's the reason why it's a little bit toxic when compared to the first and third generation TKIs. So afatinib is known for its activity, wonderful activity in exon 19 and of course in 21, and also on rare mutations. So because of its broad spectrum of action, where you have a blanket EGFR inhibition, so it's very likely that few squamous cell carcinomas are also EGFR driven. So we do have some trials where anti-EGFR like cetuximab, for example, FLEX trial has shown some OS benefit, and to the surprise, the magnitude of benefit with bevacizumab in adeno versus cetuximab in lung are almost similar, but unfortunately, bevacizumab has become a winner in contrast to cetuximab in squamous cell carcinoma. So just mean to say that EGFR inhibition is extremely productive, and it is worthwhile targeting this particular pathway. So, so squamous and EGFR go hand in hand, and we have evidence of afatinib even in head neck cancers where those patients who are post-platinum setting, again you want to give oral therapy. We have solid data for afatinib in squamous. So there is always a relation of EGFR, squamous carcinomas, a broad spectrum potential EGFR inhibition clinically. So with this in background, we can go for how the trial was designed and what the results are. So these TKIs, even if it's an EGFR unselected population, these TKIs do work. And importantly, the moment you speak of squamous, the amount of EGFR mutation is less than 4% in studies. So we don't routinely do EGFR testing for squamous carcinomas. However, in spite of that, in these EGFR unselected population, EGFR inhibition is productive and it has shown survival benefit. So with this in background, we can understand the design of the trial and how the trial goes. So I was speaking of the HER2 pathway. So these are the receptors over the surface of cell. So usually there is cell multiplication only when there is a ligand that is coming and sticking to the receptor, and that causes multiplication of cells. But if there is autonomous proliferation because of autonomous EGFR activity, So basically, EGFR belongs to the ERBB family, and it has EGFR, HER2, and HER4. And inhibiting all these, it's a sort of a pan ERBB inhibitor or a pan EGFR inhibitor is what is afatinib. Broad spectrum, irreversible, very potential. Therefore, you get excellent efficacy and you have to manage the toxicities. So this is the class of second generation TKIs like afatinib. So, these are the receptors where afatinib acts. Therefore, even in a HER2 positive lung cancer, or we do use afatinib as an option. So, with this in the background, where afatinib works, what is the mechanism of action, how is afatinib different from first generation TKI, we can go on to further study. So, this is a LUX-Lung. LUX-Lung is a group of trials in lung cancer where they have addressed specific questions in each trials, starting from adenocarcinoma, exon 19, and then they speak of combination of taxane with afatinib. And here, this is LUX-Lung 8, where afatinib is head-to-head compared with another TKI, erlotinib, in squamous cell carcinomas. So you can see this particular study, it's a randomized study. You can see the advanced non-small cell lung carcinoma, squamous histology, stage 3, 4, stage 3B or 4, more than 4 lines of platinum-based doublet chemotherapy, which is standard treatment in the first-line setting, ECOGPS 0 and 1 with adequate organ function. And those patients who had a response, who did not have disease progression, were excluded. Prior TKI, EGFR TKI or antibody were excluded, and active brain mets or interstitial lung disease was excluded. And the randomization was in 1:1 fashion, where few received afatinib 40 OD versus erlotinib 150 OD. And so this was the randomization they had, and it was continued until disease progression or unacceptable adverse events. The stratification was East Asian versus non-East Asian, tumor tissue collected for correlative signs, radiographic tumor assessment at baseline, week 8, week 12, 16, and every 8 weeks thereafter. So this is how the design of the study was. And these are the key primary endpoints: progression-free survival by RECIST, overall survival was a secondary endpoint, and the secondary endpoints were response rates, disease control rate, tumor shrinkage, quality of life, and safety in both treatment arms. These are the baseline characteristics. Uh, you can see the baseline characteristics of both the groups. You can see the number of patients, excellent number of patients, more than 300 patients in each, and ECOG 0, 1. You can see non-East Asian, East Asian, smoking history. You can see nearly never smokers were 8, 3, 5 in each group. Then the majority was smokers. This is the classical way of squamous cell carcinoma. So that means even in smokers where we have not tested EGFR, even in this set of population, this drug is effective. So we could look at the majority was stage 4. Squamous cell carcinoma was more than 95%, and it was not just adenosquamous. And the prior chemotherapy they used was platinum-based doublet, and they did have 50% had some response, 50% had stable disease, and unknown responses around 13%. So if you look into the results, the progression-free survival, which is the primary endpoint, you can see a statistically significant progression-free survival benefit of 2.4 versus 1.9 months, with a hazard ratio of 0.8 and the confidence interval not crossing unity. You can see the parallel tail of the tail, the way we see with targeted therapies. So you can also see that the separation starts nearly after 2 months, where both Erlo and Afa works in the initial, but later on, when actually the EGFR driver mutation is inhibited, then comes the action of afatinib, which is very potential, and then starts separating. So what you can note is nearly 50% population benefit with this drug, and the benefit is quite significant, and the PFS is prolonged. So statistically different, and the difference starts at 2 months, uh, and the difference starts separating more potentially with afatinib than erlotinib. And this is the updated progression-free survival data by independent review. Even here you can see a statistically significant progression-free survival difference. Even here the separation starts at around 2 months. Again, the p-value is significant and well within confidence intervals. And you can see at 6 months and at a 9 months interval, there is a statistically significant difference. So this is excellent. You can look into the overall survival, statistically significant 7.9 versus 6.8 months. So if you're using an oral drug, if there is prospect, instead of using erlotinib, we must use afatinib, and this is the evidence we have in front of our eyes. 1 year overall survival significantly different. Again, 1.5 year survival different. So there is a statistically significant overall survival difference in this particular study, stating that afatinib is more productive. So this is the forest plot. You can see that the diamond is always on the left side, whether it is in smokers and irrespective of response to prior therapy, and then whether it was light smoker, never smoker. So everything favors afatinib when compared to erlotinib. So this was the subsequent systemic therapies. There was no availability of IOs, so you can see only 0.3% have received subsequent therapies. But however, in the present era, IOs will come before TKIs. If there is prospect, if there is no prospect, then TKIs will be the way to go. So IOs have caused nothing else but financial toxicity, and not everyone can afford an immune checkpoint inhibitor. Majority of squamous cell carcinoma patients belong to a low socioeconomic status. They're smokers, they have addiction to tobacco, either smoky or smokeless tobacco, and this set of population needs some therapy which is oral and effective. So, so this is how it was. And then they looked into a biomarker analysis, and is there any test which predicts the response to EGFR TKs in squamous cell carcinoma? And this was the evaluation of the very strat serum protein test in patients with advanced squamous cell carcinoma in patients with the LUX-Lung 8 study. So very strat is the name. It's a serum protein test that identifies the host patient response to the tumor by measuring several acute phase reactant proteins in blood. It uses matrix associated laser desorption ionization time of flight. It's a very complicated name, and by mass spectroscopy quite technical. So VeriStrat test has shown prognostic and predictive utility for EGFR targeted agents in non-small cell lung cancer. So the blood sample for VeriStrat were collected from all patients with LUX-Lung 8, and the clinical outcomes were analyzed with respect to VeriStrat status. Out of 795 patients, 675 patients did undergo the test, and 412 patient samples were classified as VeriStrat good, and 263 were classified as VeriStrat bad. And this is the difference in VeriStrat good. You can see the overall survival nearly coming up to 1 year. You don't even see 1 year overall survival in first line chemotherapy. So excellent way of going. You have a biomarker like VeriStrat, and if it is VeriStrat good, you must offer afatinib to these set of patients. So you can see the statistical significant difference in overall survival, 11.5 versus 8.9, and looks like VeriStrat in itself good in itself is a prognostic marker and also a predictive marker for response to TKIs. So the PFS with afatinib was erlotinib in good versus poor. You can see there is a significant PFS difference as far as afatinib is concerned. So these are the responses. You can see the waterfall plot. You can see the responses, quite deep responses have been seen in the afatinib group and compared to the erlotinib group. So you're benefiting around 50% of patients, and in whom it is benefiting in a significant way. And the way to select it is by doing VeriStrat testing. So the duration of response was 7.29 months for afatinib and 3.7 months for erlotinib. So this is the symptom improvement and the patient reported outcomes. So you can see here dyspnea, coughing favors afatinib, whereas pain is right in the middle. And again, if you look into the global health scores, again it favors afatinib. So there is symptomatic improvement. This is what matters. Quality of life and overall survival are the two important endpoints that we need to look into. And if you look into the side effect profile, of course, diarrhea rash is little higher in the afatinib because of its potential anti-EGFR inhibition. Otherwise, if you can dose right, it is fairly well tolerated. So to summarize, of course, immune checkpoint inhibitors are the way to go in front line or in subsequent lines of squamous cell carcinoma. But the problem with it is not all patients with squamous carcinoma afford immunotherapy, plus not everybody benefits with immunotherapy. Financial toxicity, plus it is effective in only 30% patients. What about that 70% and the huge chunk who cannot afford? So practically only 10% of our patients can afford such expensive therapies. So in those patients who have progressed post-platinum, and we have evidence here of giving oral drug afatinib, so 40 milligram OD, and if not tolerating, can come down, and we have a statistically significant progression-free and overall survival difference with erlotinib. So this is the evidence we have, and we have a biomarker which I just discussed in the VS good and the VS poor population. So that is the way to select out these patients. So this is the take-home message, that squamous cell carcinomas have an EGFR-driven cancer. And in those patients who have progressed on first-line platinum-based therapy, oral therapy with these drugs improves progression-free survival, improves overall survival, and improves quality of life of these patients. So whenever feasible, we must offer these drugs to these patients. So with this, I would thank Boringa Vingalam for providing the opportunity. And back to you, Dr. Pankaj, for further discussion and closing the session. Thank you.